So, hello everyone. So, am I audible and visible to? Is my voice is clear to you guys and my screen is visible to all? Am I audible to you guys?
Yes, sir.
Okay. So great. And my screen is visible to everyone. Okay. So great. So in last class we have discussed about the absorption, where we have covered some of the MCQs related to the drug absorption and also clearing some of the concepts regarding to the drug absorption. And I have given a broad overview of the how the drug has a fate whenever it is administered into our body, what is the fate, how it is eliminated, distribution, etc. So while coming to the in detail discussion of the ADME, where I have covered the A property, now today we are going to cover the two properties, distribution and elimination. If the time permits, then we can also talk about the some of the basics of the other subject, which is pharmaceutical analysis. So now let us start our discussion to the drug distribution. So basically, drug distribution. So basically, drug distribution is nothing but a reversible phenomena in which whenever a drug enters into the bloodstream, it gets distributed to the different tissues. So basically, a reversible transfer of the drug from the blood to the different tissues and between the tissues. So this whole phenomena is known as distribution, drug distribution. So basically, drug distribution should compulsorily occur, because if our drug is remain in the systemic circulation, then the blood, when it flows to the kidney, then it will get eliminated to the body. So for a drug to reach its site of action, let us consider these as a site of action. The drug must get distributed from the blood vessel to the site of action so that it can show its intended action. So basically, during drug distribution, there are many types of barriers for which the drug encounters. So can you guys tell me what are the different barriers which are present in our body which restricts the drug distribution? Come on, guys, quick. What are the different drug distribution barriers which are present in our body which restricts the drug distribution? Simple capillary endothelium barrier. Great, Vivek. Next. Come on, BBP blood-brain barrier. Great, guys. Next. Come on. Blood testicular barrier, placenta barrier, blood placenta barrier. Great, guys. So there are many different cerebrospinal fluid barrier, CSF barrier, brain CSF barrier. So these are the some of the quite most popularly known drug-brain barriers. So as I mentioned, disposition. So in last class, I have mentioned the term disposition. So can anyone tell me what does the disposition? So what two terms makes the disposition? What two term combination makes the term disposition? Come on, guys. In last class, I have discussed how the two terms get uh, coincide each other and they form the disposition term. So basically, the distribution and elimination together are known as disposition process. So first one, distribution, which involves the reversible transfer of drug between the compartments. So compartment is nothing but the different tissues. So basically, our body is divided into many compartments. So each compartment is known as each tissue. So basically, the distribution of the drug occurs between the different compartments. Next, elimination. So elimination is nothing but the reversible loss of the drugs from the body. While the distribution is the reversible, the elimination is irreversible. While the elimination composed of two, biotransformation and excretion. Biotransformation is also known as metabolism, which primarily occurs in the liver, and excretion mainly occurs from the kidney. So why the biotransformation should take place, guys? Say me, why does the biotransformation should take place? What is the main role? What why should their body, a drug should undergo biotransformation reaction? Answer to it, guys. Answer to this question. Why a drug should undergo biotransformation reaction? So basically, the main rationale behind the biotransformation is basically to convert in order to increase the hydrophilicity of the drug, mainly to increase the to take, yeah, great answer. So basically to increase the hydrophilicity of the drug, to make it more easily excreted from the body. So as we know that our urine, through urine, the drugs which are excreted should be hydrophilic. Otherwise, the lipophilic drugs get reabsorbed from the kidney. So basically, these are going to be contents of the today's topic on the distribution. So first of all, as I mentioned, definition. So definition, which signifies that distribution is a reversible transfer of drug between one compartment to the another compartment. One compartment to the another compartment. So basically, the blood compartment is known as intravascular, and the tissue compartment is known as extravascular. So the distribution also can be seen as the uh, reversible movement of the drug from the intravascular to the extravascular. So basically, come on guys, say me, for a drug to have a therapeutic action, the concentration of the drug should be more in extravascular or should be in the intravascular? Answer to it, guys. For a drug to show a therapeutic action, its drug concentration should be more in extravascular or in the intravascular. Come on, guys, answer it. Yeah, great, guys, great. So whenever a drug is more in extravascular, it is more is bound towards the tissue and it shows the most action. So significance. So basically, what is the main purpose of studying drug distribution of a drug? What is the rationale of studying the drug distribution of the drug? So basically, onset of action, intensity of action, duration of action. So basically, as we have seen that the plasma drug concentration time curve. So basically, this is the absorption event. This is the elimination event. So basically, the drug concentration increases and the drug concentration decreases. So basically, the fluctuation in the concentration mainly occurs due to the distribution of the drug. So basically, onset of action and intensity and duration of action, these three things depends upon the distribution. So basically, steps in drug distribution. So basically, the main important role. So for an organ to receive a drug, a two main factors influences mainly the blood flow to the organ and the rate of permeation of the drug. So rate of permeation to the extravascular tissues and membrane permeability of the drug. So basically, come on, guys. These are the two main rate limiting steps or these slower steps or the rate determining steps in the distribution. So for which kind of drug, the rate of perfusion rate is rate limiting step. For a drug to have a rate of perfusion as a rate limiting step, what properties does the drug possess? Answer to it, guys. Basically, what properties that a guys have a better understanding of the question. The rate determining step for distribution is rate of perfusion to the organ. Rate of perfusion to the organ. Because the drug is A hydrophilic, B lipophilic, C amphiphilic, D neutral. Answer to this question, guys. Answer to this question. Answer to this MCQ. The rate determined step in the distribution is the rate of perfusion to the organ because the drug is. Come on, guys. Answer to this question. First of all, whenever you get an MCQ, try to read the MCQ and understand the rationale. Great, guys. Great. So the option is the lipophilic. So mainly the lipophilic because the lipophilic drugs do not have the rate limiting step of the permeation. They have the good permeation, but their distribution depends upon the rate of blood flow to that organ. If the rate of blood flow increases to that organ, their distribution also to that organ also increases. So the answer is B. So while coming to the membrane permeability of the drug, it is the rate determining step for the hydrophilic drug. So basically, this is the whole distribution process. So this is the blood. So simple barrier, which is the capillary endothelial barrier. So basically, all drugs carries can able to permeate this capillary endothelial barrier and enter into the extracellular fluid. Extracellular fluid is nothing but the fluid which is present outside the cells or outside the tissues. So then from the drug from the extracellular fluid and enter into the intracellular fluid. Intracellular fluid inside it is nothing but the cytoplasm. This is the cytosol. So basically, the cell membrane of the cell can be crossed by like bulk flow, which is nothing but pro transportation, passive diffusion, active transportation. So basically, these are the properties of the drugs by which they goes to the different mechanisms. So basically, distribution is a passive process. Obviously, as the we have talked about the passive diffusion, which is the main process. 90% of the drugs which are absorbed through intestine via passive diffusion. So here are the same. The distribution does not require any utilization of the energy or ATP, for which the driving force is the concentration gradient between the blood and the extravascular tissue. So the process occurs by the diffusion of free drug until the equilibrium is established. But as we know that in our body, never the equilibrium get established. So basically, this is the overview of the different organs, their blood flow, their mass, and the normalized blood flow. So basically, the kidney has the highest blood flow, followed by the liver has the highest blood flow, followed by kidney, CNS, myocardium, fat, other. So basically, these are the different factors which affect the drug distribution. So the factors are generally classified into four types. The first factor includes the tissue permeability of the drug. So basically, permeability of the drug, which is the second rate determining step, which is mainly the rate determining step for the hydrophilic drugs, depends upon the some of the physiochemical properties of the drug like molecular weight, pKa, partition coefficient, etc. For example, the molecules with the lower molecular size can easily permeate through the barriers when compared to the molecules which are having the larger molecular weight, molecular size. Let us consider this is as a one molecule and this as a one molecule. So basically, this molecule will require more, this molecule will have the more hindered to have the permeation. Next, pKa. So depending upon the pH of the blood and the pH at the tissue site, the drug may undergo ionization and unionization. And basically, we know that the unionized form of the drug has the more lipophilic characteristics by which it will have the more permeation. Next, it is nothing but the partition coefficient, which is nothing but the log P value. So a drug which have the higher log P value will have the higher permeation rate, but up to a certain limit. Next, physiological barriers to the diffusion of the drugs. Initially, which I have asked a question, different types of barriers. There we have mentioned the blood-brain barrier, blood testicular barrier, blood placental barrier, etc. Next, the organ and tissue size and perfusion rate. Next, binding of the drugs to the tissue components. Then binding of the drugs to the blood components and extracellular components. So basically, main the drug binding to the blood components can be drug can bind to hemoglobin. It can also bind to the plasma proteins which are present in our blood and etc. So basically, the physiochemical properties, as I mentioned earlier, molecular size, pKa, partition coefficient, and these are the top barriers for the drug distribution, which includes the blood testis barrier, blood placenta barrier, blood cerebrospinal fluid barrier, blood-brain barrier, which is the main barrier, which mainly protects the drug from the toxins, etc., to prevent their entry into the brain. Next, simple cell membrane barrier. So every cell has a simple cell membrane barrier, and the cell membrane is generally made up of the phospholipid, same like as the intestinal cell barrier, and simple capillary barrier, as I mentioned earlier. So molecular weight. So as I mentioned here, so molecular weight less than 500 to 600 Daltons can easily pass the capillary barrier to the extracellular fluid. As I mentioned that, so here, see, this is the capillary barrier, and drugs which are having the molecular weight up to 600 Daltons can easily able to cross this capillary barrier and enter into the extracellular fluid, basically this fluid which is present outside the tissues. and penetrate the drug from the extracellular fluid to the cells is the function of the molecular size, ionization constant, and lipophilicity of the drug. So from extracellular fluid to cross the cell membrane to the aqueous fill channels. So aqueous filling channels is nothing but the pore channels, where I have mentioned generally the size ranges from the 4 to 10 Armstrongs, needs particle size less than 50 Daltons, and should have the hydrophilic property. So what is the driving force for the transport through the aqueous fill channel, guys? What driving force act as the drug transport through the aqueous fill channels? Answer to it, guys. What driving force which causes the transport of the drugs to the aqueous fluid channels? Hydrostatic pressure. Great, Vivek. Great. Chintu. So generally, the larger molecular size restrict or requires specialized transportation. As I mentioned, that larger molecular size have the more difficulty in the permeation when compared to the smaller molecules. Next, while talking about the degree of ionization, so degree of ionization, the pH at which the drug is ionized is called pK. And as I mentioned, that weakly acidic, these all terminologies have been discussed in the yesterday's class. Well, I mentioned that weakly acid become unionized in the strongly acidic environment. Weakly acid get ionized in the neutral or basic environment, and this the same applies to the base, vice versa. So basically, as we know that the mainly the pH of the blood, extracellular fluid and cerebrospinal fluid is 7.4. So let me frame your question, guys. So let not here basically. The pH at cancer cancer cells is acidic, basic, neutral, or it is 7.4. Come on, guys. Answer to this cancer. The pH surrounding the cancer cells is. Come on, guys. Answer. Answer to this question. The pH surrounding the cancer cells is. Come on, everyone must answer to this question. The pH at the surrounding the cancers, it must be acidic, basic, neutral, or 7.4. Come on, guys. Everyone must answer to this question. It is acidic due to the increasing the metabolism around in the cancerous cells. So next we can come on the O by W, which is known as KO by W, which is nothing but the log P or partition coefficient. So polar and hydrophilic drugs are less likely to cross the cell membrane, where the non-polar and hydrophobic drugs, because having the more lipophilicity, can able to cross the cell membrane. So effective KO by W is nothing but fraction unionized by fraction of KOW in unionized. So basically, the amount of drug unionized in the oil divided into the unionized drug is 7.4. So in case of polar drug, where the permeability is rate limiting step in distribution, the driving force is the effective partition coefficient of the drug that can be calculated by the effective above formula. So basically, this is the effective partition coefficient, which is nothing but the fraction of unionized drug at the pH 7.4 and the KO by W of the unionized drug. So lipoidal drugs are able to penetrate the tissue rapidly among drugs which is same partition coefficient but differ in the ionization at the blood pH. So even though the two drugs having the same log P value, but due to the difference in the ionization at the blood pH, which is typically 7.4, the permeability of the those two drugs will be get differ. So basically, one which has the less ionization should show the better distribution because it would have the better lipophilicity. And this is the generally the phenobarbital and the salicylic acid. Both has the same log P value, but the phenobarbital is more unionized at the blood pH. That's why it has the more permeability. Next, we move our discussion to the different types of physiological barriers which are present in our body at the different sites and which hinder the drug distribution into that tissue. So first coming to the simple capillary endothelial barrier. So basically the drug molecular weight less than 600 is basically does not act as a barrier. So all drugs, whether it may be ionized form or unionized form, molecular weight less than 600 daltons, can easily diffuse through the capillary endothelial barrier or interstitial fluid to interstitial fluid, which is nothing but the fluid which is present outside the tissues. So only the drug that bonds to the blood components, they can't able to pass through this barrier because of large size complex. So basically, the drugs which are bound to the plasma protein are can't able to cross the blood endothelial barrier, by which they remain in the uh, blood for the longer period of the time, by which the TF of the drug increases. So basically, guys, the drug which is bound to the plasma protein can be metabolized or excreted. Is it metabolized or excreted? The drug which is bound to the plasma protein, does it is prone to metabolism and excretion? Answer to it, guys. Yeah. So basically, the drug which is bound to the plasma protein, due to its larger molecular weight, the enzymes are can't able to metabolize the drug, and also through GFR, which is nothing but the
Hello, Praveen.
epinephrine. Hello.
Praveen, just one request from the YouTube people. A little bit, can you just zoom your screen?
Okay, sir. Is it enough?
Is it possible if you can do more?
Okay,
Little
sir.
bit
Sure.
more?
I think this may
Yes,
not
this is
possible.
fine to go. Yes.
Okay, sir. Thank you. So basically, uh, so the drug which is bound to the plasma protein is generally inert and do not show any pharmacological action. It is not neither metabolized nor excreted from the body, because basically this is the Bowman's capsule, and we this is Bowman capsule and the blood vessels which come here. So basically here filtration occurs. So basically the drug which is bound to the plasma protein has the larger size, by which it is can't able to penetrate through this. It is restricted, by which it is not eliminated from the body, mainly by the kidney. Next, which is nothing but the simple cell membrane barrier, which is basically the barrier surrounding the cells, which is generally made up of the phospholipids bilayer. So once the drug diffusion through the capillary to the extracellular fluid, which I have mentioned, that the fluid which is present outside the cell, the further entry into cell is limited, because this barrier is mainly lipophilic in nature, and only the lipophilic drugs can able to permeate through the cell membrane barrier, and it is not an inherent property of every drug. So the hydrophilic drug, in order to cross that cell membrane, they have to utilize any other transportation mechanism to cross the cell membrane. So as I mentioned, it's similar to lipidal barrier. Non-polar and hydrophilic drugs will pass. No, it's not hydrophilic. It is hydrophobic. I think it is a mistake in the presentation. This is not hydrophilic. This is hydrophobic. Lipophilic drugs with 6,550 to 600 daltons and molecular weight will pass it. As I mentioned, the less than 50 daltons. Why the less than 50 daltons drug can able to pass? Which mechanism is applying when the drug is less than the 50 daltons? Which mechanisms apply for the permeation when the drug molecular weight is less than 50 daltons? Come on, guys, answer to my question. Answer. Everyone must be interactive in the class. Come on, guys. Why the hydrophilic and polar drugs with less than 50 daltons are able to pass the membrane? It's not diffusion. It is basically the pore transport. As I mentioned earlier, pore transport. Great, guys. Great. Next, the most important barrier. Yeah. So most important barrier, it is nothing but the blood-brain barrier. So blood-brain barrier. So in normal blood blood walls, the endothelial cell have sufficient gap between them. But while coming to the blood-brain barrier, the endothelial cells are tightly bound to each other. Basically, there is no gap between the endothelial cells while coming to the. See, here there is no endothelial barrier. There is specifically no gap. There is no gap. There is a tight junction. Here you can see these are the tight junctions which are present between the endothelial cells. So these are the tight intracellular junctions by which Basically, from the blood-brain barrier, the paracellular transport does not occur. So only way to cross the blood-brain barrier, only two. One is the carrier-mediated transport, which can be a facilitated diffusion or active transport, and another one is the transcellular. And the transcellular mainly can be caused by the highly soluble lipid-soluble drugs, highly lipid-soluble drugs. Along with that, the blood-brain barrier also consists of the astrocytes and pericytes and glial cells, by which they further form the tight junction, by which the permeation through by crossing the blood-brain barrier further decreases, and it is very difficult to cross the blood-brain barrier. So capillary in the blood are highly specialized and much less permeable to the water-soluble drugs because the endothelial cells are tightly bonded with each other by intracellular junctions. And as I mentioned, that it consists of the astrocytes present present at the base of the endothelial cells, and it acts as a supporting materials. So basically, all astrocytes form an envelope around the capillary, thus intercellular passes get blocked. As I mentioned, that paracellular transport do not occur in the blood-brain barrier. And basically, the blood-brain barrier is a totally lipoidal barrier. So drugs with only high partition coefficient, basically log P greater than 3, diffuse passively, others moderately lipid soluble and partially ionized passes slowly. So the high log P molecules can pass easily and faster way. So while coming to the polar natural substance, the transport is actively, thus structural similar drugs can pass to the blood-brain barrier. So what does this statement signify? So basically, whatever the essential nutrients which are required for the brain's normal function, those all essential nutrients are cross the blood-brain barrier by the presence of the specific transporters on the surface of the blood-brain barrier. So if our drugs has this structure similar to that essential nutrient, then that one can as a substrate for that carrier and can able to cross that blood-brain barrier. So basically, there have been a quite different approaches have been used to increase the permeation of the drug to the blood-brain barrier, because most of the drugs which are act on the CNS system should must cross the blood-brain barrier in order to show their therapeutic action. So basically, there are different approaches, or we can say the ways which are used to increase the permeation to the blood-brain barrier. So first one, which includes the permeation enhancer, which includes the DMSO, dimethyl sulfoxide, dimethyl formamide, etc. While we can use the prodrug. So basically, why the prodrug? So is the prodrug are the active or the inactive, guys? Answer to me, guys. Is the prodrug are the active in nature or inactive in nature outside the body?
Inactive.
Yeah, inactive. Great, guys. So basically, after metabolizing in the body, they get into the active form. So prodrugs are basically designed to enhance the solubility and also for the various parameters. So one of the parameters to increase the lipophilicity. So basically, the dopamine is converted into the levodopa. Levodopa has the more blood-brain barrier penetration, and inside entering into the brain, the levodopa converted into the dopamine. So which enzymes causes the conversion of levodopa to dopamine, guys? Which enzyme causes the conversion of the levodopa to dopamine? Come on, guys. Answer to this question. Yeah, great. The carboxylase. So basically, the dopamine being highly water soluble can't able to permeate the blood-brain barrier. So we convert into the levodopa. Levodopa enters into the blood-brain barrier, where by the enzyme decarboxylase, it converts into dopamine and it shows this action. So basically, it's using the Parkinsonism. And also by osmotic disruption by the blood by infusing the mannitol in the internal carotid vein. So basically, the classical carrier system which is available in our blood-brain barrier is the dihydropyridine redox system. So by forming the complex with the dihydropyridine, the drug become the lipophilic, and after entering into the, so basically, let us consider these as a barrier. So here with the drug, the dihydropyridine forms a complex. This complex penetrates to the blood-brain barrier. So inside the brain, this complex cleaves, and by which the drug is show action into the brain. and polar pyridium, which is formed, it cannot able to diffuse it back. So basically, these are the old pathway where we have to be shown the different like insulin and transferrin are transferred by receptor mediated endocytosis, transcytosis, adsorptive transcytosis also occurs. Here transport proteins are the present. So these are the different pathways. So these are the tight junction which I mentioned earlier, that neurons, tight junction, endothelial, etc. So another one's barrier is the cerebrospinal fluid barrier. So basically, the cerebrospinal fluid is produced by which ventricles in the brain? Name the ventricles. Say me the which ventricles produces the cerebrospinal fluid. Which ventricles in the brain? Which ventricles in the brain produces the CSF, cerebrospinal fluid? Come on, guys, answer it. Which ventricles produces the CSF? I think basically the third and fourth. I think so. I can able to recall the third and fourth ventricle mainly produces the CSF, cerebrospinal fluid. So basically, the capillary endothelium here you can see that while compared to the blood-brain barrier, here the tight junctions are not present, but the tight tight junctions are present in the choroidal cells. Choroidal cells. So basically, crossing the drug here is easier, but crossing the drug here is difficult. That's why they have to follow the transcellular pathway. So capillary endothelial cells have the open junction, so drug can flow freely between the capillary wall and the choroidal cells. The choroidal cells, the tight junctions are present between the choroidal cells, but are absent between the endothelial cells. So next, well, coming to the discussion, which is nothing but the blood placental barrier. So blood placental barrier is the one of the most important type of barrier in the pregnant woman, because the blood placental barrier determines the which type of drug should enter into the fetus during the pregnancy. So during the pregnancy, so the baby get exposure to the different types of drugs. So that's why and the placental barrier is quite permeable to the water soluble drugs also. So that's why only some of the drugs are only used during the pregnancy. Not all drugs are used into the pregnancy. So why the drugs which cause the toxic effects to the fetus are known as, there is a specific term, the drugs which cause the toxicity to the fetus. Such kind of drugs are known as. Come on, guys, answer. Heterogenic. Great, guys, great. So those kind of drugs are known as heterogenic drugs. Great, guys, great. So that's why the main there is a limitation in the drug administration, and only specific amount of drugs are only given during the pregnancy or the maternal period. So basically, this is how the whole placenta barrier looks like, which consists of the fetal artery and fetal vein of the baby. This is the fetal membrane, which is made up of the trophoblast and endothelium. This is the maternal artery and maternal vein. So basically, this is the whole how the placental barrier look like. So placental barrier. So this barrier between the maternal and the fetal blood vessels. So both are separated by the fetal trophoblast, and the thickness during the initial months it is thick, but as the baby grows and the fetus grows and the fetus develops, the thickness of the barrier get decreases to the 2 micron, by which it is more permeable in the latter stages of the pregnancy when compared to the earlier stages of the pregnancy. So here you can see this, guys. Molecular weight less than 1,000 and moderate to highly liquid soluble drugs, sulfonamides can cause the simple diffusion easily. That's why the sulfonamides, barbiturates, steroids, antibiotics are not used during the pregnancy. And while coming to some of the essential nutrients, and for the fetal growth are transported by the carrier-mediated transport, and the immunoglobulins are transported by the endocytosis. So basically, in two stages, the drug is dangerous to the fetus. In first trimester, the drug can produce a teratogenic effect. Example, phenytoin in methotrexate. So I think so. Phenytoin causes something to the baby. That syndrome is known as. You guys can able to remember what does the phenytoin when administered to the pregnant woman causes to the fetus? Come on, guys. You have to be so that you can able to recall your pharmacological adverse effect or the teratogenic effect. What does the phenytoin causes to the fetus when it is administered? I think you guys are able to recall it. Fetal Hydantoin syndrome. Great, great, guys, great. So these different types of syndromes are very important, guys. Every year, approximately 3 to 4 questions or 2 to 3 questions are in pharmacological are asked about these syndromes. So affect the respiratory diffusion, like the morphine causes the respiratory depression, etc. So this is next blood testis barrier, which is nothing but the sectorial and sectorial cells junction barrier. So basically, barrier restricts the passage of the drugs to the spermatocytes and spermatids so that it may can destroy the spermatogenesis process. So organ tissue size I mentioned. So perfusion rate limited occurs when the drug is highly lipophilic and drug membrane process which the drug is diffused to diffuse. So these are the different as I mentioned, these are the different organs, blood flow, their mass, and their we have to only remember the order. It is not important to remember these values of the blood flow, mainly the order. So if they may can ask the what is the different order of perfusion. So they can and give the different combinations, like they can and give fat first, then mitochondrium, then CNS. So you have to guys remember this order: liver, kidney, CNS, myocardium, fat. So mainly these four. So as I mentioned, that drug distribution is permeability limited when the drug is ionic or water soluble or polar in nature, which restricts the distribution. So distribution will be perfusion rate limited when the drug is highly lipophilic, when the membrane is highly permeable. So perfusion is defined as the volume of fluid, volume of blood that flows per unit time, per unit volume of the tissue. So the units of the perfusion rates are the ml per minute per ml. So basically the T of, so T of, we can do the distribution T of is nothing but 0.693 by KT. So which is nothing but the KTB, which is nothing but the tissue to blood partition coefficient divided by the perfusion rate. So highly lipophilic drugs can cause the blood-brain barrier, etc. As I mentioned here, that's why the thiopental also has the high VD and high. Let us I wanna further talk about the concept of the VD. So high permeable capillary walls permit the passage of the almost all drugs. The highly perfused tissues like lungs, kidney, liver, heart, brain are rapidly equilibrium with the lipid soluble drugs because these do not have any barrier to the permeation. So drug distribution in a particular tissue depends upon the size of the tissue and the tissue blood partition coefficient. For example, thiopental, which is lipophilic drug, has the high tissue blood partition coefficient towards the brain and adipose tissue. That's why it has the more accumulation in the brain and adipose tissue. So, being the brain as a highly perfused organ, so drug was distributed fast and shows the rapid onset of action in the brain. Then it is so less later onset of action in the adipose tissue. So basically, binding of the drug to the blood and the other tissue compartments. So basically, here comes the most important topic in under the distribution. So basically, I think, do you guys able to recall the what is the volume? So basically, so can anyone tell me how much volume in liters of the vascular fluid, blood fluid by volume? So blood fluid volume. Do you guys able to recall it? What is the approximate value of the blood fluid in our body? How much liters? Is a 40, yeah, it is approximately, yeah, six, approximately say six liters. Blood fluid, extracellular fluid, 5 to 6 liters. Yes, extracellular fluid. What is the amount of extracellular fluid in our body? Come on, guys, say me the value. It is basically 12 liters. And the intracellular fluid, this question has been asked in the GPAT 2022. 2022. Intracellular fluid is 24 liters. So basically, different types of markers which are used for the different types of tissues. So 1 minute, guys. 1 minute. So for the plasma compartment, which marker is used, guys? Come on, guys, answer to this question. Which marker is used for the plasma compartment? Evans blue. And Evans blue, and there are other markers also. Evans blue albumin grade. And next, Evans blue mark indocyanin green grade. Indocyanin green, and I1 radioactive isotopes 131 is used. For erythrocytes, which marker is used? Chromium 15, chromium 51. It's not 151, it's 51. Chromium 51. For extracellular fluid, raffinose, inulin, mannitol, and for the total body water, it's not insulin, it's inulin. There is a huge difference between the inulin and the insulin. For the total body water, the classical example D2O, deuterium oxide, and antipyrine. So this table is also very important, guys. These tables you have to remember different markers. So basically, now let us start our discussion. So basically, there are also different methods which are used to study the drug distribution, which includes the microdialysis method, MALDI, MSI, autoradiography, positron emission topography. So these are the different are also used to measure the which is nothing but the drug distribution. So basically, plasma protein basically uses human serum albumin binds to the mainly all types of drugs. Basically, it binds to the acidic drugs. Alpha 1 acid glycoprotein binds to the basic drugs. Lipoproteins basically as they binds to the basic and lipophilic drugs like promazine. Alpha 1 globulin binds to the steroids like cortisone, vitamin B12. Alpha 2 globulin binds to the vitamin A, D, E, and cupric ions, hemoglobin. So the drugs which binds to the hemoglobin has been asked in the second phase in the GPAT 2023, which includes the phenytoin and phenothiazide. So you have to remember, guys. They have also asked the drugs which binds to the RBC or hemoglobin. I can't able to recall it, but they have asked any one of them. So RBC, which includes the 40% of the blood, and 90%, out of 95%, if the blood 40% of the blood consists of the blood cells, and among the 40%, the 95% are the RBC, and the drugs which binds to the hemoglobin are the phenytoin, phenobarbital. So guys, can say me what is the central atom present in the hemoglobin? What central metal ion is present in the hemoglobin? What central atom it is present in the hemoglobin? Iron. So iron, it is present in the ferrous state or ferric state? Ferric state. Ferric or ferrous? It is as ferrous or ferric. Guys, come on. Don't get, I want clear answer. So basically, depending upon the oxygenated state, it can exist in the ferrous and ferric state depending upon the oxygenated state. So next major component RCB comprises of the three major components which I mentioned: hemoglobin, carbonic anhydrase, cell membrane. These are the you have to be known as this basically order. This order is very important to you guys. So albumin, acid, alpha 1 acid glycoprotein, lipoprotein, and the globulin. So this is very important, guys. Most abound protein with large drug binding capacity, both endogenous compound and drug bind to the human serum albumin. So there are the four different sites on the albumin, which are the warfarin, azoproposon, diazepam, digoxin, and tamoxifen. So tissue components. So tissue binding also is increases. As the binding increases the biological half-life. So as we can know that irreversible binding can lead to the toxicity. So irreversible binding mainly occurs due to the covalent interaction. So basically, this is the binding order: liver, kidney, lungs, muscle, etc. The miscellaneous factors are these guys. So age. So basically, the total body water is greater in the infants. The fat content is higher in the infants and the elderly, by which the more lipophilic drugs get accumulated in the fat and have the longer residence time. Skeletal muscles are lesser in the infant and elderly, and the obviously the in fats and the children, the blood-brain barrier is poorly developed, by which the permeability of the most of the drugs increases. So this is the pregnancy. During pregnancy, due to growth of fetus, increase in the volume available for the distribution of the drugs. So diet, a diet with high fat will increase the free fatty acid circulation and thereby affecting the binding of the acidic drugs. Because the acidic drugs mainly binds to the albumin, and the fatty acids and bile also binds to the albumin, by which there can be a competition between the both the molecules. So disease state. So during the disease state, so there can be a tissue damage. There can be a increase up regulation or down regulation in the plasma proteins, which may can overall affect the which is known as distribution. So altered or reduced perfusion to the organ or tissue, altered tissue pH. As I mentioned, in the cancer, the pH becomes acidic. Alteration of the permeability of the blood-brain barrier to the damage of the any of the in meningitis and encephalitis, the BB becomes more permeable to the polar antibiotics. Displacement interactions occurs. So basically, apparent volume of distribution is the proportionality constant relating to the plasma drug concentration total amount. So basically, VD is nothing but the X by C, amount of drug present in the body by plasma drug concentration. So drugs with larger apparent volume are more concentrated extravascular tissue and less concentration intravascular tissues. So VD is nothing but X by C. So for the drugs which are given by the IV bolus, so X naught by KE into AUC. So these have to be remembered. This is the formula. I will not go with the derivation because derivation requires more time. But for the sake of the time, you guys have to remember the formula of the VD when the drug is administered by the IV bolus, and formula of the VD when drug given by the extravascular. So what does the F indicate, guys? What does the F indicate? Do you guys know what does the F indicates? Do you guys know what does the F indicates? So F indicates the bioavailability factor. So basically, so for IV route, the F value is 1, 2, 3, D, 0.5. For IV administration, the value of F is the value of F. Everyone must answer to this question, guys. The value of F for the IV administration is. Everyone must answer to this question. The value of F when the drug is administered via IV. It is basically 1. And what is the molecular weight of the albumin? What is the molecular weight of the albumin? The molecular weight of the albumin is the 65,000 daltons. And also the alpha 1 acid glycoprotein is also known as orocomucoid. And the globulins which are present in our body, there are different globulins which I have mentioned, that alpha, beta. So alpha 1 globulin, alpha 1 globulin. So alpha 1 globulin is also known as transporting protein or corticosteroid binding site. Corticosteroid binding site. Corticosteroid binding site. While alpha 2, alpha 2, alpha 2 is called ceruplasmin, ceruplasmin, and it binds to the vitamins like ADE. Okay? Beta 1, mainly the transferrin binds to the beta 1. So basically, these are the different types of the globulins which are present in our body, and the different. So apparent volume of distribution has the no direct relationship between the real volume of distribution, because the amount of fluid present in our body is not defined. Some people may have the more fluid blood volume or the tissue fluid in the one person, and another person can have the low fluid. So that's why there must be a generalization regarding the apparent volume of distribution. So drugs that selectively binds to the plasma protein blood component have the apparent volume of distribution less than the true volume of distribution. Example, the warfarin has the PD of 10 liters, because the true volume of distribution has the 42 liters, but the apparent volume of distribution get differs. Drugs that selectively binds to the extravascular tissues have the apparent volume of distribution more than the true volume of distribution. Example, chloroquine. Chloroquine has the highest volume of distribution, and these also been asked in the GPAT 2023. It is around 64,000. So basically, this is the problem. Solve it, guys. So if the dose administered is the 225 mg, plasma concentration of the IV bolus is the 10 mg, what will be the VD? Come on, guys. Answer to this question. Answer to this question. If the dose, use the formula VD is equal to X by C and calculate and answer me, guys. Answer to this question, guys. Great. 22.5. 22.5 in liters. And for IV bolus, if the dose is administered 0.1 mg and plasma concentration is this, then we can get the IV as a 30,000. So you can calculate. These are the three sums which I have added. You can do after the class, guys. So basically, these are the further questions which I have placed. So you can place it, guys. So basically, so another important things which we can have discussed here is the basically determination of plasma protein. The determination of plasma protein binding. Determination of plasma protein binding can be done by the two methods. One is direct technique, direct method, and second one is the indirect method. The direct method. So direct method include the use of the UV and fluorimetry, and the indirect method uses the different methods like equilibrium dialysis, dynamic dialysis, ultrafiltration, gel filtration, etc. So basically, as the lipophilicity of the drug increases, the extent of binding also increases. So basically, the albumin has the more binding sites when compared to the other proteins which are present in our body. So this is all about the excretion. So do you guys have any doubt up to now in distribution? Do you guys have any doubt in the distribution? Does anyone has any doubts in the distribution? So that we can move our discussion to the next concept of excretion. Do anyone has any doubts in the distribution? I think no one has any doubts. So let us start our discussion to the excretion, elimination, which is nothing but. So excretion of the drugs. So elimination, as I mentioned, that elimination uh, and distribution comes under the terminology disposition, and elimination is nothing but a irreversible formula, irreversible thing, and expression where the termination of the action of the drug takes place for metabolism. So predominantly it occurs in the liver and the kidney. Mainly it occurs in the liver, and also it occurs in the GIT also. So excretion of the unchanged drug or its metabolite prominently by kidney. So excretion is nothing but the drug is getting removed from the body so that its action get terminated. So basically the excretion is also a defense mechanism which a body follows so that the accumulation of the drug inside the body does not take place. So as I mentioned that the major excretion organ is the kidney. So other than kidney, the excretion can also takes place from the gut, skin, lungs, sweat glands, breast, and salivary glands. So as I mentioned, basically in addition, there is a third process of termination of drug action is the process of redistribution of the drug. So basically by redistribution of the drug gets moves away from its site of action and it goes to any other site of action where it can't able to show its action. So drug elimination, the onset of pharmacological response depends upon the absorption and the distribution, and duration and intensity of action depends upon the tissue redistribution and rate of elimination. So here you have to remember, guys, whenever the onset is given depends upon the distribution and the absorption. Duration and intensity of action depends upon the distribution and the elimination. The distribution remains same in the both teams, only the here absorption comes, here the elimination comes. So excretion is a irreversible transfer from the internal to the external environment, which is nothing but away from the body. So basically, renal excretion and non-renal excretion, lungs, biliary, intestine, salivary glands, and sweat glands. So basically, from the biliary system, mainly the highly lipophilic drugs are eliminated through the next oxidation to the cytochrome P450 metabolite formed by the renal excretion. If it forms the stable attacks, conjugation if it forms the stable X, which is the lipophilic in nature, then by biliary elimination and elimination to the stool. So basically, this is the renal drug clearance. So agents that are excreted in the urine are the water soluble, non-volatile, less than 250 microdaltons, and metabolized slowly. So basically, the three process which occurs for the elimination of the urine excretion of the drug, which includes the glomerular filtration, active tubular secretion, and active or passive tubular reabsorption. So basically, the functional unit of the basic and functional unit of the kidney is the nephrons, and there are such millions of nephrons together present in kidneys, which helps in the elimination of the drugs. So basically, the two arterioles, the efferent and efferent. E which nothing but the E indicates exit. So which exit from the Bowman's capsule, and A which enters into the Bowman's capsule. These together forms the glomerular glomerulus, and from here the filtration occurs and the blood anchors the waste products enters into the tubules. So mainly Jakasi has the three TCT, DCT, Vasa recta, which is nothing but the ascending loop of Henle, descending loop of Henle, and the collecting duct. So basically, this is the whole structure of the nephron, and this you have to also be studied in the human anatomy and physiology, and also while studying the diuretics. So this is ascending loop of Henle. This is the descending loop of Henle, where the ascending loop of Henle only the water reabsorption occurs. That's why the concentration of the solute increases from the as the filtrate moves from the down the ascending loop of Henle, because only the water reabsorption takes place, and as the in the descending and in the ascending loop of Henle, the solute reabsorption takes place. That's why it leads to dilution. So basically, the glomerular filtration. So basically, excretion is defined as the filtration minus reabsorption plus active secretion. So reabsorption is nothing but the movement of the drug from the tubule to the blood, and secretion is nothing but movement of the drug from the blood to the tubule. Secretion, secrete out. So GF, glomerular filtration, water and inbound drugs and metabolites, active tubular secretion of the acidic and basic drugs and metabolites, active tubular reabsorption basing upon their properties. Lipophilic drugs are reabsorbed while the hydrophilic drugs are secreted out. So glomerular filtration rate, as I mentioned. So which marker is used to indicate the GFR, guys? What markers are used to determine the GFR? It has been asked in the NIPER 2023. Which marker is used to measure the GFR? Inulin is correct, but there is one of the classical marker, the most widely used marker, creatinine. Yes, whenever there is an option, first you have to pick the option of creatinine, because creatinine is one of the most widely used marker to measure the glomerular filtration rate, and basically it ranges from the 120 to 125 ml per minute. As I mentioned, it is non-selective and unidirectional. So most of the compounds, whether it may be ionized or non-ionized, are filtered, except those are bound to the plasma protein. As I mentioned, that their size increases. The driving force is the hydrostatic pressure, as same as the pore transportation. The glomerular also has the negative charge, same as the uh, intestinal membrane. Substance used, as I mentioned, creatinine, inulin, mannitol, and sodium thiosulfate. Sodium thiosulfate is less used. Next, active tubular secretion. Active tubular secretion is nothing but carrier mediated, capacity limited, and saturated. So wherever the carrier comes, the saturation comes, and the non-linear pharmacokinetics or mixed order kinetics comes into the role. It mainly occurs into the PCT, requires energy for the transportation of compound, exists the concentration gradient because it is carrier mediated and it requires the energy, unaffected by pH and protein binding depending upon the renal flow. So basically, it occurs by the mainly two transportations, mainly organic anionic transporter and organic cationic transporter. So basically, by organic anionic transporter, basically the penicillin, salicylates, glucuronides, sulfates, and uric acid are sulfur. So as you can see that there is a classical drug interaction between the probenicid and the penicillin. So basically, what happens is the probenicid inhibits the organic anionic transporter, by which the active tubular secretion of the penicillin get inhibited and the plasma drug concentration of the penicillin increases. For the organic cationic transporter, which is nothing but the OCT, which is also written in short form as the OCT, and it is also known as OAT. So morphine, mecalamine, hexamethonium, endogenous amine like catecholamines are like this. So there can be a competition between them. So half-life of the both drug is increases since the total sites on the active secretion are the limited. So drug with the greater rate of clearance will retard the excretion of the other drug, which will commit. So I also mentioned the classical drug-drug interaction between the penicillin and the probenicid. So here the comes probenicid inhibits the active tubular secretion of the organic acids like penicillin, para-amino salicylic acid, para-amino hippuric acid, 17 ketosteroids, and increases plasma concentration by 2-fold times. That's why the probenicid also acts as a uricospheric agent used in treatment of the gout. It suppresses the carrier-mediated reabsorption of the endogenous metabolite like uric acid. So probenicid acts as a uricospheric drug because it inhibits the reabsorption of the uric acid. So inhibition of the nitrofurantoin secretion by the probenicid decreases its efficiency. Tubular reabsorption. So tubular reabsorption results in the increasing the TF of the drug. So mainly the highly lipophilic drugs and the glucose electrolytes are mainly undergo the tubular reabsorption. Vitamins, amino acids, drugs like oxypurinol. So passive tubular reabsorption mainly depends upon the concentration gradient, while the active tubular reabsorption mainly requires the ATP, which means nothing but the energy. So as I mentioned that lipophilic substances are actively reabsorbed compared to the polar substances. And also basing upon the pH and pK of the drug, if the drug remains as a unionized form, then it will be actively reabsorbed. If it remains as a ionized form, then it will be actively secreted. For example, let me have a MCQ for you guys here. in case of acidosis, to increase the excretion of acidic drug, the urine pH should be option A 1.2, option B 2.2, option C 3.2, option D 8.4. Great, guys. Because everyone must answer to this question, guys. I don't want the answer from only one person. Everyone must answer to this question. So the answer is D. So basically, what happens is in acidosis, generally we make the urine alkali so that we can able to increase the excretion of the acidic drug by which it can get ionized. Great, great, guys. So reabsorption is inversely proportional to the urine flow rate. So this is basically the pH. See, acidic drugs such as penicillin or a basic drug such as gentamicin, which is polar in its ionized form, not reabsorbed passively and irrespective of the extent of urine flow rate. Basically, the rate of excretion is the sum of the rate of filtration and the rate of active secretion. Because reabsorption decreases the rate of elimination from the body. So again, it comes the action of the pH and the pK of the drug, where which we have mentioned earlier in the intestine also. So very weakly acidic drugs and non-polar drugs which have the pKa greater than 8, such as phenytoin, or very weakly basic drugs and non-polar drugs having pKa propoxyphene, are mostly ionized throughout the entire pH of the urine and therefore extensively reabsorbed passive at the or urine pH. So basically, the strong acids and the strong bases remain unionized form throughout the urine pH by which they get extensively reabsorbed. So these is the further depending upon the pH and the pKa, as I mentioned, that difference and the how much acid ionized and how much acid is unionized. So depending upon the drug urine pH, you can able to calculate it. So here it comes the toxicity due to the overdoses of the drug whose excretion is sensitive to the pH sense can be treated by acidification or alkalization of the urine with ammonium chloride or the sodium bicarbonate respectively, as I mentioned here. Thus, the crystallosuria, which is caused by the precipitation of the sulfonamides in renal tubules, can be cause kidney damage can be overcome by the alkalizing the drug because the sulfonamides are acidic in nature. So the again comes the same thing. The excretion of the basic drugs can also be promoted by the acidification of urine and therapeutic activity. So this is an example which I mentioned here. So basically, these are the different factors which affects the renal excretion for which occurs. So basically, this is another important table which you have to remember, you guys. So basically, molecular weight less than 300, major excretion in the urine less than 5% in bile, greater than 500 daltons, more excretion in the bile, less excretion in the urine, because less than 250 are able to cross the GF, basically the Bowman's capsule. Next 350 excretion both in urine and bile. So another same the properties also applies here. Lipid solubility. So urine excretion is inversely related to the lipophilicity, as you guys know, because lipophilic drugs are mostly reabsorbed. Stereochemical nature. So chloroquine, diazopyramide, terbutaline are selectively secreted by the kidneys because they are depends upon their optical nature. So GFR and reabsorption directly affected by the plasma drug concentration. So clearance is inversely related to the VD. So we know that CLT clearance is equal to KE by VD. So drugs with large VD are poorly excreted in the urine because the drug with large VD are more deposited into the tissues by which their excretion decreases. So basically, this is the urine of the pH, which depends upon the pK of the drug, which is determined by the which equation, guys? Which equation to determine the concentration of ionized and unionized? Which equation is used, guys? Which equation is used to determine the percentage ionized and unionized by using the values of the pH and the pKa? Anderson-Hasselbalch. Great, guys. Great. Anderson-Hasselbalch equation. This has been taught in the last class, guys, where the pH is equal to pKa by log ionized by non-ionized for weakly acidic. You have to remember here, you guys, for the acids, the ionized comes in the numerator, while for the base, the ionized comes in the denominator. Renal blood flow. So important for the drug excreted by the GFR and only those to the actively secreted. So increasing the perfusion rate increases the contact of the drug with secretory site and increases the secretion. So perfusion rate limited. So basically, renal excretion is 10% lower in the females when compared to the males. And in the newborn, the kidneys are not developed that much, by which the retention time in the body also increases. And in old age, the GFR is decreasing and excretion is decreasing. So basically, there are the different drug interactions which occurs between the different drugs, which may be inhibit their drug reabsorption, tubular secretion, etc. So classical example which is gentamicin induced nephrotoxicity by furosemide, because furosemide displaces gentamicin from the protein binding, by which the gentamicin causes the nephrotoxicity. Gentamicin, next drug interactions. So alteration of the urine. So by acidification and alkalization of the urine, we can able to selectively eliminate the drug from the body. For example, acidification by the ammonia, chloride, methionine, and ascorbic acid can be used to eliminate the basic drugs. Example, morphine and amphetamine. By citrates, tartarates, bicarbonates, acidic drugs can be eliminated. So probenicid, cimetidine is a competitive inhibitor of the organic cationic transport system. So diuresis is nothing but the increase in the elimination of the drug, where we in pharmacology, where the Payam sir will have been taught to the different drug classification of the diuretic drugs. So basically, during the renal dysfunction also, they impairs the elimination of the drugs primarily excreted by the kidney, like during the nephropathy, etc. cases. So now let us have a discussion on the non-renal routes of energy. So basically, these are the different non-renal routes. Maybe these are of the minor importance, but through these routes also, the excretion occurs. So while coming to the biliary excretion, mainly the highly lipophilic drugs are mainly excreted by the biliary excretion, and the bile is excreted by the hepatic cells. The flow rate is generally 0.5 to 1 ml per minute bile is excreted, and 90% of the bile which is excreted in the small intestine is reabsorbed back to the intestine and transported back to the liver. So greater the polarity, better the excretion. This is the rule of thumb. This is the rule of thumb, guys. Greater the polarity, better the excretion. The metabolites, that's why the metabolites are more excreted in bile than the parental due to increasing the polarity also. So biliary excretion is also active process, capacity limited. These are the different class of the drugs which are excreted by the biliary excretion, and these appears in the fecal matter, which includes quinine, colchicine, vinblastine, D-tuberculin, vancomycin, corticosteroids, erythromycin, and chlorpromazine. So basically, this is how the excretion from the bile occurs. So basically, in liver, the bile gets stored into the gallbladder, and to the bile duct it comes into the intestine, where it causes the emulsification, then it occurs bile duct enter into blood and again comes into the liver. So which is nothing but the enterohepatic circulation, where the drug gets circulated between the liver and the intestine, because the main reason for the enterohepatic circulation is the drug becomes the substrate for the bile acid transporters. So the drug releases along with the bile, and the drug get absorbed along with the bile, by which the drug get rotation between the liver and the intestine, and the residence time of the drug in the body increases, which may lead to the toxic effects. Examples: oral contraceptives. So by the enterohepatic circulation, uh, the TF is increased and the drug action is also increased. So basically, the certain drug metabolites can, particularly glucuronides, are excreted to the bile and delivered to the intestine, where these metabolites are deconjugated or dehydrolyzed, releasing the parent active drug again. This free drug is reabsorbed and cycle is repeated. So basically, for example, a drug is conjugated by the glucuronide conjugation. So it enters into the intestine where it is get hydrolyzed, and this free brome of drugs and again enter into the blood and it enters in the liver. So this cycle repeats between the liver and the intestine. So here free drug glucuronide conjugate comes to the bile duct due to the presence of the GIT gut bacteria, which is known as microbiota. Free drug which again enters into the blood portal way. So this cycle repeats, and some of the drugs can also be eliminated through the fecal matter. So basically, this is the enterohepatic circulation. Here we have to remember, guys, oral administration, drugs enter in small intestine. Some of the drugs can be eliminated to the fecal matter and small intestine, hydrolyzed conjugates, etc. So these have been taught to you earlier that 300 Daltons, 500 Daltons, 300 to 500 Daltons. So this is also mentioned that polarity is directly proportional to the excretion. So basically, the biotransformation reaction. So the why the biotransformation reactions occurs is to mainly increase the hydrophilicity of the drug. So increasing the hydrophilicity of the drug is the main rule of the metabolic reaction by which they can be easily eliminated from the body. So phase two reactions, phase one and phase two reactions, as we can know that phase two reactions are also known as. Does the phase two reactions are the synthetic reactions or non-synthetic reaction, guys? Answer me. The phase two reactions are the synthetic reactions or the non-synthetic reactions? Phase two reactions are the synthetic. Yeah, great, guys. So these are the synthetic reactions. So phase two reactions, mainly the drugs which undergo the glucuronide conjugation are mainly undergoes the enterohepatic recirculation. So pulmonary excretion, mainly the highly drugs which are mainly volatile in nature and the gaseous drugs, those all are excreted from the pulmonary route. So gaseous and volatile, just like halothane, are absorbed through lungs and by simple diffusion. So pulmonary blood flow, rate of respiration, solubility, these all are the different factors which mainly affects the pulmonary excretion. Mainly the gaseous drugs are excreted, but not the metabolites. So alcohol, which has the high solubility in the blood and tissues, are excreted slowly by the lungs. That's why uh, whenever it, we can, some of the alcohol is also excreted to the lungs. Next is salivary glands. So we can know that there are different types of salivary ducts which are present in our mouth, which include the sublingual, submandibular, parotid duct, etc. Salivary excretion. So basically, this pH of the saliva varies from the 5.8 to 8.4. So mainly the unionized liquid soluble drugs are excreted passively through the saliva, and whenever a drug is excreted through the saliva, a bitter taste have been experienced by the patient. So basically, the salivary excretion do not require any kind of energy. It is a passive diffusion process and it depends upon the pH partition coefficient. So basically, the more basic drugs are more eliminated to the saliva when compared to the acidic drugs. And these are the different types, examples of the drugs which are eliminated to the saliva, which includes lithium, tetracycline, metronidazole, pyrazinamide, penicillin, ethosuxinamide, etc. So whenever a drug is get excreted from the saliva, so it is also important that we have to also know the how much amount of drug is getting eliminated by saliva. So memory excretion also weekly basic drug concentrate more in blood. So these are the important drugs which are mainly eliminated by the milk, which includes chloramphenicol, tetracycline, morphine, bromocriptine, diazepam, estrogen, oral contraceptives, etc. So this is basically this how the excretion takes place. So chloramphenicol can cause the bone marrow depression, diazepam, because the milk is taken by the baby, and whenever due to the memory excretion, the chloramphenicol can enter into the baby's body and it may cause the bone marrow depletion. Diazepam can cause the sedation. Heroin can cause the neonatal dependence. Methadone can cause the withdrawal symptoms. And propylthiouracil causes the suppression of the thyroid functions. So these are the different side effects which are caused by the drugs because they are excreted through the memory glands, while tetracycline is a classical which affects the bones and the teeth. Sulfonamides connect us. Penicillin causes the allergy. Ampicillin causes the diarrhea. Dapsone causes the hemolytic anemia. Phenidone bleeding. Phenobarbital drowsiness. Phenytoin methylglobulin and theophylline restlessness. So there is also these skin excretions, but is also minor in nature. So mainly through hair follicles, arsenic, mercuric iodides are excreted and creatine. So basically, crisoflumin is one of the classical antifungal drug is excreted through the keratin. So urea derivatives like alcohol, benzoic acid, ethanol, amphetamine are excreted. So this is basically the fecal, where which through bile, which includes the corticosteroids, cholestyramine, etc. These all are drugs are administered are mainly get eliminated via the fecal matter. So these are the different references which you can go through. So this is all about the distribution and the elimination. So up to now, do you guys have any doubts? Do you guys have any doubts? Do you guys have any doubts regarding this up to now? So basically, uh, some of the extra concepts which we can also have a discussion while coming to the renal clearance. So, so basically, which is known as the renal clearance ratio. So let me discuss with you guys what is meant by the renal ratio. So let me find a blank space, blank space. So basically, the clearance ratio, clearance ratio is the ratio between the clearance of the drug divided by clearance of creatinine. So basically, its value ranges from 0 to 1. It's not 0 to 1. It can be up to more than 1. So basically, there is a relationship between the renal clearance ratio, renal clearance. So let me give you guys idea. So when the renal clearance, renal, so I will basically write the RCR, which is nothing but renal clearance ratio. So if the renal clearance is 0, then this also becomes the 0. Then the drug is mainly filtered and reabsorbed. Basically, the drug is not getting clear from the body. So drug is filtered by the GFR, filtered, but it is totally 100% reabsorbed. Next, if it is less than 130, then the ratio ranges from the 0 to 1, depending upon the value which is less than 130. The drug is filtered and partially reabsorbed and partial reabsorption. If it is 130, then the 130 by 130, which is basically 1. So drug is filtered only. Drug is only filtered. If it is greater than 130, if it is greater than 130, which signifies that the clearance of the drug is higher when compared to the clearance of the creatinine. So the value would be greater than 1. So drug is filtered filtered and secreted actively. If it is 650, then the renal clearance value approximately gets to 5. Then the clearance is equal to renal plasma flow rate. So basically, this is the whole concept of the here. You guys, you have to remember here. This is very important table. So basically, the examples. Do you guys know which kind of drugs are filtered but 100% reabsorbed? Can anyone say me the example? Can anyone say me the example of the drugs which are filtered but 100% reabsorbed? Come on, guys. Answer to my question. 100% reabsorbed. Lipophilic drugs are never, ever are 100% reabsorbed. It is glucose. And the partial reabsorption comes the lipophilic drugs. What would be the third drugs which are only just filtered? Come on, guys. Inulin. Great. Inulin and creatinine. This one, what will be the examples of the drugs? Polar and hydrophilic. Great. Polar. And for this, where the clearance is directly proportional to the renal blood flow rate, endoparasite. Great, Vivek. Great. Iodopyrosite. Iodopyrosite. Pyrosite and para-amino hippuric acid. Hippuric acid also. So this is also have to be remembered, guys, by you guys. So basically, whenever there is a renal damage in the patients, we basically we either decreases the dose of the drugs, or we also extend the dosing interval. So basically, whenever a patient is suffering with the renal function or renal disease, we can't able to administer the normal dose which is given to the patient, because it may can lead to accumulation of that drug in the patient body. In that case, we either reduces the dose of the drug, or we increases the we increase the dosing interval. So there is a formula. So patient dose to normal dose into renal function. So renal function is calculated, and another concept is the patient dose normal dosing interval divided by renal function. So, so basically, these are the two way by which we can adjust the patient's dose, or we can modify the dosing interval. We can also do the reduction in the dose by keeping the same dosing interval, or we can have the no change in the dose, but we can increase the dosing interval. So basically, I'll give you the formula of the renal function. So basically, the renal function is the ratio between the clearance of creatinine, by patient divided by clearance of creatinine by normal person. So basically, this is the formula for the renal function. So these you have to get remember. You have to remember this, guys. So that's all for the today, guys. So let us have the discussion in the next class. Do anyone has any doubts up to now in the absorption? Sorry, in the distribution and the elimination. Okay. So great, guys. So that is for today. In next class, we're gonna meet with the new topics, new discussion, and new MCQ, guys. Thank you for joining. Good night, everyone.